It's the top of the hour. We'll get started. I'm Dia Waguespack in Houston. I'd like to welcome everyone to today's GlomCon. Today is one of our clinical trials conference series, which is a joint venture between GlomCon and Nephrology.
All right, thank you very much for having me here to talk. I realize that actually both my name and the drug name are quite a so my name is Hetal Kocinsky, and I'll be talking about targeting C3G and primary IC-MPGN with a drug called Pegcetacoplan. Just as a reminder, Pegcetacoplan is an investigational compound for these diseases for C3G and IC-MPGN. It's not approved to treat these diseases by any regulatory authority. I will mention that we did recently get approval for Pegcetacoplan for the treatment of PNH in the United States and are pending a decision in Europe as well. Okay, so we're going to start by talking about these two diseases, C3G and IC-MPGN, and they have a very intertwined history. And so what I'm going to focus on today is not so much the history and the nomenclature, but to focus on the similarities and the differences between these two diseases. So C3G and IC-MPGN are both rare chronic kidney diseases that are thought to be caused by sustained and inappropriate activation of the complement system. And this leads to excessive production of C3 and C5 breakdown products, which are then deposited in the glomeruli to kidney damage. And this kidney damage is devastating in the sense that many patients, up to 50%, will progress end-stage renal disease within 10 years of diagnosis. Renal transplantation is an option for these patients, but disease recurrence is common in the allograft, and in about 50% of patients will actually lead to allograft loss. Now, the diagnosis of these two diseases is relatively complex in that it requires both clinical and pathologic evidence. And so on the right, we have some pictures, some pathology, histopathology pictures, and we'll talk about histopath in more detail later in this talk. But the first picture shown here, and can everyone see my cursor? No. Yes? Okay.
Yes, we can see.
So this first picture here is light microscopy, and light microscopy typically shows an MPGN pattern of injury for both C3G and IC-MPGN. It's really immunofluorescence that distinguishes between the two diseases. And what's shown here on immunofluorescence is what these two diseases have in common, which is that they both have C3 deposition in the kidneys, so deposition of C3 breakdown products, and this usually the staining is for C3C. Now, the way they differ is whether or not, or to what extent, there is also immunoglobulin deposits. So in C3G, the deposition is primarily C3 breakdown products, whereas in IC-MPGN, you actually have either dominant or even stronger than C3 staining immunoglobulin staining. And then lastly, electron microscopy is used to distinguish between the two types of C3G, dense deposit disease and C3 glomerulonephritis. So these are diseases with a high unmet need because there's no approved therapy that targets the underlying disease pathophysiology in these and prevents progression to end-stage renal disease. So in talking about the underlying disease pathophysiology, as I said before, in both diseases, C3G and primary IC-MPGN, the underlying problem is believed to be overactivation of the complement pathway. Now, as a reminder, the complement pathway has three arms: the classical, the lectin, and the alternative. And all three arms then converge on C3. So when the complement pathway is activated, regardless of which arm starts the activation, you get activation of C3, which leads to its breakdown into C3A and C3B. C3A is a potent anaphylatoxin, which leads to inflammation, including within the kidney. C3b then also is found deposited in the kidney, but also goes on to form the alternative pathway C5 convertase, and so then allows the complement cascade to continue by breaking down C5 into its breakdown product, C5a, another anaphylatoxin, further increasing the inflammation, again, also kidney, and producing C5b, which goes on to form the terminal complement complex and also leads to damage within the kidney. Now, in C3G and IC-MPGN, in C3G, it's believed that the disease really begins within the alternative pathway. For IC-MPGN, it's